the increased amount of glucose. In hypertension, because of the hemodynamic changes, the endothelial injury happens. And in diabetes, because of the increased amount of glucose, which damages the endothelium. And in this, the damage is only functional. That is, the endothelium is not denuded. वो गायब नहीं हो जाती, लेकिन जो सेल्स हैं उनकी कैपेसिटी जो है वो इम्पेयर हो जाती है. सो नॉर्मली द सेल्स एंड द प्रोटीन्स जो कि वेसल वॉल में नहीं घुस सकते, दे गेट द सेल्स इम्बाइब दोज leukocytes and proteins. Okay, so the nephrosclerosis, which is the hallmark of diabetes, it develops due to this type of arteriosclerosis, because in this the afferent arteriole, it gets narrowed due to the arteriosclerosis. When the afferent arteriole gets narrowed, the blood supply to the glomerulus is compromised. When the blood supply is compromised, there occurs ischemia, and then fibrosis of the glomerulus occurs, resulting in nephrosclerosis and kidney failure in the diabetes. Okay, understood? So, this simple arteriosclerosis is also very, very important because it leads to changes ischemia in hypertensive patients and in diabetic patients. Now the second type is the hyperplastic one. In this, here you can see there occurs concentric smooth muscle replication and the internal elastic membrane reduplication occurs. So there is concentric layering of the smooth muscles and the internal elastic membrane. This is known as the onion skin layering. And in the malignant hypertension, in addition to this layering, there can be fibrinoid deposits and vessel wall necrosis also. This is known as necrotizing arteriolitis, which happens in malignant hypertension. Now, the second variety is the Monckeberg's medial sclerosis. Here in this, there is calcification of the muscular arteries. Okay, in simple, it is the small arteries and arterioles. Here it is the medium-sized muscular arteries which are involved, and it involves the internal elastic membrane. Only the internal elastic membrane. Calcification of the internal elastic membrane occurs, and it does not affect the lumen. That is, lumen is not narrowed, nothing occurs, and therefore clinically it is not impaired because the function of the artery is not impaired. And it is mostly seen in the uterine vessels. Here you can see the purple colored deposition that is occurring. It is in the internal elastic membrane and the lumen is normal. Okay. So when the lumen is normal, the uterine muscles, they are perfused normally and there is no ischemia. So now we come to the most important one, the atherosclerosis. Now the word atherosclerosis means, it is derived from a Greek word athero, that means porridge, and sclerosis means scarring. So the core of the atherosclerosis, the plaque that occurs, this is a soft lipid-laden porridge-like material, and this is covered by a connective tissue cap which is known as the scarring. Now this affects usually the intima of the large and medium-sized muscular arteries and the large elastic arteries also. So we see that is affecting the intima. When it affects the intima, the lumen will be affected, it will be compromised, and it will lead to ischemia. Now, at first it was widely prevalent in developed countries, but improved therapies have now reduced mortality and morbidity in the developed countries. But now it has increasingly prevalent in the developing countries, Because first is mortality from the infections has decreased in developed countries, and secondly, the risk factors, the lifestyle risk factors that were first present in the developed countries are now present in the developing countries. So there are a number of risk factors involved in atherosclerosis, and these risk factors, they do not have an add-on effect. Rather, they have a multiplicative effect. So if two risk factors cause the increase the risk by 4 times, three risk factors will cause an increase by 7 or 8 times. Now the risk factors, the major risk factors, there are major risk factors and minor risk factors. They are divided into constitutional and modifiable. Constitutional means you cannot do anything about them. You cannot change them. They are not in your hands because they are related to the genetic abnormalities, to age, gender, and familial and racial factors which are not in your hand. You will have to live with them. And second is the modifiable risk factors. That is, even if you have constitutional risk factors in you, but if you make changes according to the modifiable risk factors in your life, you can keep atherosclerosis at bay. And these risk factors are hyperlipidemia, hypertension, diabetes, smoking, and any type of inflammation in body. Your genetic and familial and racial factors, they are interlinked, and some have familial hypercholesterolemia in families, and it has been found that they have an increased risk of atherosclerosis. Then these risk factors, they are usually polygenic, that is, multiple number of genes are involved in this, and there are also racial differences, like blacks have a less severe disease than whites. Then as the age increases, the risk of atherosclerosis increases, and it is mainly between the age of 40 to 60 years that the incidence rises sharply. And because the risk of atherosclerosis increases in this age, the risk of myocardial infarction also increases with the same frequency. Now, it is usually more common in, yeah, you can come today because it's raining and I was also late, but from tomorrow you'll have to be on time. But this is the last time that I'm allowing entry after 9:20. So this is more common in men, especially in the premenopausal age, maybe because of the protective influence of the hormone estrogen. And in the post-menopausal age, the incidence in women overtakes that of men. And if you, even if the estrogen is supplied, the rate of development of atherosclerosis it does not change. Now we come to the modifiable risk factors. So in this first was hyperlipidemia. It is more specifically hypercholesterolemia that is involved. And if there are no other risk factors and only there is hypercholesterolemia, it increases the risk of atherosclerosis to a very high level. And you know the various components, LDL, VLDL and HDL, so I don't think so I have to tell you. So what does HDL do? Anybody? It is a good cholesterol. And what does it do? Why is it a good cholesterol? Good. So, from the peripheries, when it transports, it clears the arteries and the arterioles. So, there will be no cholesterol to get deposited and no atherosclerosis to form. Now, what are the causes of increased cholesterol? First of all is diet. In this high intake of saturated fats and baked goods, obesity and smoking. Both of these lowers the level of the HDL. They do not have much effect on the overall cholesterol, but it lowers HDL and familial hypercholesterolemia. So, how can we have said that it is a modifiable factor? So, how can we manage it? So, we can manage it by lowering LDL, and this is done by drugs, compounds known as statins. And these statins, what do? They inhibit the enzyme hydroxymethyl glutaryl coenzyme A. So you should know that what drugs, if it is used, what exactly do they cause. So they reduce the enzyme, they inhibit the enzyme hydroxymethyl. Yes, the first row. If you have anything to say, you can come here and say. So this is a rate limiting step in the hepatic cholesterol synthesis. So if this enzyme is involved, it is inhibited, the amount of cholesterol that is synthesized will be reduced. Then by increasing the amount of HDL, this you can do by exercise, by weight reduction, and by use of drugs, nicotinic acids. Then you can take diets which are low in cholesterol or high in HDL, like omega-3 fatty acids like in fish oils. Second was hypertension. In this, both the systolic and the diastolic levels, they are important. And why hypertension is important? Because it causes injury to the endothelium due to increased pressure. And once the endothelium is injured, the rest of the process of formation of atherosclerosis will start, as we will read in the pathogenesis of the atherosclerosis. And on its own, that is, if there are no other risk factors, hypertension increases the rate of atherosclerosis by 60%. So, if someone has hypertension, you have to explain them that it is not only the hypertension, but later on you will have a tendency for heart disease also. So, it is very important to control your blood pressure. Now, smoking. Now, smoking is a well-established risk, and maybe it was presumed that in men, atherosclerosis is more because incidence of smoking in men is more. But as the incidence of smoking in women is increasing, the percentage of atherosclerosis in women is also increasing. Now, what does smoking cause? Smoking reduces the level of HDL. Then there is deranged coagulation system. It causes increased coagulopathy. That is, blood tends to clot more. If there is slight injury in a smoker and non-smoker, in non-smoker maybe you will form a small platelet plug. But in a smoker, a large platelet plug will be formed. It will causes increased coagulopathy. And then because of smoking, there is accumulation of carbon monoxide. And carbon monoxide has more affinity for hemoglobin than oxygen. So, more of hemoglobin will be occupied by carbon monoxide and less oxygen will be available to the tissues, resulting in ischemia and necrosis of the endothelium, injury to the endothelium, which will have an effect on the atherosclerosis. Now, diabetes is, we have seen that one is because of the increased sugar, it will cause injury to the endothelium. Secondly, it increases the cholesterol levels. So once cholesterol levels are increased, it will cause increased atherosclerosis, and therefore myocardial infarction is twice as common in diabetes as in a non-diabetic person. And especially it is important in the gangrene of the lower limbs, because almost 100% Incidence of gangrene of the lower lobes of the lower limbs, gangrene of the lower limbs occurs in diabetic patients. Now, there is an additional risk factor, inflammation. Now, according to the new theory of the development of atherosclerosis, inflammation is present in all stages of development of atherosclerosis. So, if there is inflammation in body due to any cause, there will be release of cytokines, growth factors, and all the factors involved. So, this is a very important modifiable risk factor. If there is any inflammation, you should look to it. You should look to the source of the inflammation and correct it. So, you can assess the systemic inflammation by CRP. So, what is CRP? It is a C-reactive protein. It is an acute phase reactant. This is a non-specific inflammatory marker that is very easy to assess in a blood sample. Very easily done, and it is comparatively a cheap test. So you can assess the risk factor in the cardiac risk factors that are done. Usually now HSCRP is a common test that is done in assessing the cardiac risk factors. Then if someone has been taking exogenous hormones, especially oral contraceptives, or if there is endogenous estrogen deficiency, as occurs in the postmenopausal, if it occurs at a younger age, they have an increased risk of developing MI or stroke. Then hyperhomocysteine is a very rare cause, and only in those which are genetically predisposed to hyperhomocysteine, there will be premature vessel disease. Now, metabolic syndrome, this is very common these days because it is associated with central obesity, which is almost endemic in our population. And along with the central obesity, it is characterized with insulin resistance. That is, pancreas is producing normal amount of insulin, but the cells that it acts on, the muscle cells, etc., where the glucose is metabolized, where does insulin act? It acts on the cells which take up the glucose to metabolize it. There we see that they have developed insulin resistance. That is the same amount of with the same amount of insulin, they cannot metabolize the same amount of glucose that they were metabolizing earlier. So, the amount of glucose in the plasma will increase. It is also associated with hypertension, dyslipidemia, hypercoagulability, and a pro-inflammatory state. So, all these are that we had read the modifiable risk factors. So, along with central obesity, if someone has central obesity and these risk factors are all increased, this results into a metabolic syndrome, which these days is a very common risk factor for atherosclerosis and very endemic. So, it is very important to decrease central obesity. Then infections. Infections, mainly chlamydia and viruses such as herpes and cytomegalo as such have been named, but some other infections, if they are causing inflammation, may also be involved. Then some minor risk factors are the low physical activity, type A personality, stressful life, overall obesity, etc. Now this is important, pathogenesis. Atherosclerosis as such is very important both from the clinical point of view and also from your examination point of view. So you should understand exactly how does it develop. In the older theories, there were two older theories. One was insudation hypothesis. In this, what over there that everything occurs because the endothelial cells are damaged and they imbibe everything from the blood. कि जो भी हो रहा है क्योंकि एंडोथीलियस डैमेज है, उन्होंने सब चीज ब्लड से लिया है. तो to some extent it is okay, but it does not reflect the true picture of the atherosclerosis. And second was encrustation theory, means कि कुछ आके चिपक गया है. So in this is कि encrustations from the arterial blood on the wall of the arteries. So both are, to some extent they are true, but not the whole picture. So now the latest theory is response to injury hypothesis. So this says that atherosclerosis is a chronic inflammation and healing response of the arterial wall to the endothelial injury. So there is injury and inflammation of the endothelium, which results in a healing response, and this results into formation of the atherosclerosis. So some 6-7 steps have been documented, and the first step is the injury to the endothelium. Now, the injury to the endothelium, it is reflected in increased vascular permeability, more leukocyte adhesion, and thrombosis. Now, the cause of injury are hemodynamic disturbances, hyperlipidemia, and toxins from cigarettes infections. So, hemodynamic disturbances, they will occur due to hypertension. Hyperlipidemia, you have read various causes of hyperlipidemia, and toxins from cigarette smoking, infections, etc. The second is accumulation of lipoproteins. Because there is injury to the vessel wall, increased number of lipoproteins enter the vessel wall. Once they enter the vessel wall, they becomes oxidized. The LDL becomes oxidized, and because the oxidized, they attract monocytes. I told you it's very important. If you can read it, you are invited to go. I'll give you the attendance, but at least who are hearing, let them hear them. So the LDL that enters due to injury of the endothelial cells, it gets oxidized. And once it is oxidized, it attracts the monocytes from the blood into the vessel wall. These monocytes, they turn into macrophages, they imbibe the lipid, and they form foamy cells. The foamy cells can get then ruptured, and they release cytokines which will further attract the cells. Secondly, we had seen that due to the injury, thrombosis also occurs. Their platelets form small aggregates to the subendothelial tissue. These platelets then get activated and they release factors so that smooth muscle cell recruitment occurs. Smooth muscle cell recruitment can occur from the vessel wall and also from the stem cells in the blood. So increased number of smooth muscles will be there, and increased number of cytokines, interleukin 1 and tumor necrosis factor alpha is present. So when there is increased smooth muscle activation, there will be more matrix production. These muscle cells will also accumulate foam cells. They will turn into foam cells. They will imbibe the lipid. So the lipid accumulation is both intra and extracellular. Because the cells imbibe the lipid, they become foamy cells and then they rupture, releasing the lipid into the extracellular compartment. Here you can see diagrammatically, in the first there is injury to the endothelium, and there are the various causes of injury that I have enumerated before also. Because of the endothelial dysfunction, lipids will enter, also the leukocytes you can see, and because of the injury, the green color you can see, the platelets will adhere to the vessel wall. Okay? Then there will be the monocytes which have entered, they will become macrophage activation. The platelets will release factors, platelet activating factors, which will cause recruitment of the smooth muscles. So these smooth muscles, they will come from the vessel wall and from the lumen also. Then the macrophages and the smooth muscles, they engulf the lipid and they are turned into the foam cells. Then lastly, these foam cells will get ruptured. They will, and a soft lipid core is present. This lipid core is surrounded by inflammatory cells, the monocytes, lymphocytes, few smooth muscle cells, and this is covered by, because the smooth muscles were recruited. So this erythematous plaque, it is covered by a smooth muscle cap, and above the smooth muscle, collagen tissue develops a scar over it. So this is the fully formed erythematous plaque. So this we have read endothelial injury. How does it occur and what happens when the injury occurs? So the most two important are the hemodynamic disturbances and hypercholesterolemia. Secondly, this will read the hemodynamic disturbances. What is the evidence that hemodynamic disturbances result in endothelial injury? So it is seen that erythematous plaque, they tend to occur at the osteas where the various branches from the aorta occurs. Because when the blood is flowing in a laminar fashion, when a branch develops, that is from the blood, it will go to the side, some form of hemodynamic disturbance occurs. So the majority of the plaques, they are present where the osteas of the vessels are there. And also in vitro studies have demonstrated that if there is a completely laminar flow, a non-turbulent flow, then it leads to induction of endothelial genes which protect against atherosclerosis. Okay, so this is the evidence which points that hemodynamic disturbances cause atherosclerosis in vivo and in vitro. Understood? In vivo, where the branches are occur, it is more, also it is more common in the posterior abdominal aorta, because in that also there is pressure of the organs there and the flow is not that very laminar. Also there are various branches of the arteries, so it is more common in the posterior abdominal aorta. And secondly, in vitro studies have also demonstrated that if there is laminar flow, they develop endothelial genes which are protective or atherosclerosis. Hypercholesterolemia we have read. Then how does hypercholesterolemia cause atherosclerosis? What is the mechanism? Now they can directly impair the endothelial cell function by increasing the reactive oxygen species. You have read that the LDL is taken and then LDL is oxidized so that the reactive oxygen is produced, and then it causes, this reactive oxygen will cause damage to the membrane and the mitochondrial membranes, and it also accelerates the decay of the nitric oxide, which has a vasodilator effect. So when the nitric oxide is destroyed, what will happen? It will have a vasoconstrictive effect if there is no vasodilator. So this will again result in less amount of blood flowing into the lumen and ischemia. And the lipoprotein aggregates that are present there, they become oxidized and they cannot be completely degraded. And the chronic injection you have seen, it leads to foam cells, and the modified lipid is toxic to the cells, therefore they get ruptured and they release cytokines. So this is a vicious circle that the hypercholesterolemia leads to, that it is taken into the cells will further, they will get destroyed, and when they get destroyed they will release cytokines, so a vicious circle is formed. Morphology of the fatty streaks in this, first of all, fatty streaks developed in the vessels, and these are clinically insignificant and they may also be present in the infants, and in this you can see some amount of lipid laden cells just below the intima. They do not encroach on the lumen. The lumen is not compromised in any way. In macroscopically, you can see closely packed foam cells and small amount of lipid, collagen, and proteoglycans may be present. Now the atheromatous plaque. They are patchy in distribution. That is, they involve only a portion of the arterial wall. They do not involve the whole arterial wall. And in descending order, the commonly involved vessels are the lower abdominal aorta, coronary arteries, popliteal arteries, internal carotid artery, and vessels of the circle of Willis. And vessels of the upper extremities and the mesenteric and renal arteries, they are spared except at the ostia. So upper limbs and mesenteric and renal arteries, they are comparatively spared. Now grossly, they appear as yellowish white lesions. Diameter may vary and they are raised from the surface by a few millimeter to few centimeters. And if you do a cut section, then you can see a firm white cap and a central yellow core you will see. Then macroscopically, you can see that there is first of all, there are endothelial cells. It is lined by the endothelial cells. Below the endothelial cells, you can see there is a layer of collagen and smooth muscles. So this is the cap of the atheromatous plaque. Then lined by endothelium, and below this you can see a collagen and scarring and smooth muscle cells. Below this there is cellular area in which you will see the smooth muscle cells, the foamy cells, the inflammatory cells, and in the center you can see the lipid core. So changes in the plaque can occur: rupture, ulceration, erosion, hemorrhage. All these will lead to blockage of the lumen and will either result in ischemia. Also, the plaques can rupture and they can discharge emboli, which can go to distant areas of the body, or if the atheroma, it will cause pressure of the media, it will result in aneurysm formation. And then the aneurysm can rupture anytime and can cause mortality. So the main clinical effects of the atherosclerosis depends that whether it propagates by thrombi or emboli. It will propagate, the vessel lumen will get blocked and it will result in infarction. There can be aneurysmal dilatation and rupture, and thirdly there can be luminal narrowing. So it will result in myocardial infarction, cerebral infarction or stroke, aortic aneurysm, peripheral vascular disease in which gangrene of the legs is very important, and ischemic bowel disease or infarction of the small bowel. So that's all for today.